Ophthalmology. Next, we have a talk on electrophysiology, application in neuroophthalmology, often untouched topic in neuroophthalm. And this talk is by Dr. Natasha Radhakrishnan, professor and consultant in retina, Amrita Institute of Medical Sciences.
Good morning to all. The electrophysiological test, as you know, is based upon the recording of electrical potentials evoked by visual stimuli, and either on the surface of the eyes, with the electrode situated either on the surface of the eyes, the periorbital skin, or scalp. They are non-invasive, and the important thing is they give, just like the visual fields, function-related indication. And it's of greatest utility when you have also a clinical scenario. And the ones that we are going to touch upon today are the pattern ERG, multifocal ERG, EOG, and visual evoked potentials are the types of electrophysiological tests that are important, but the visual evoked potential is most important in neuroophthalmology, so we'll be dealing with that in detail. The visual electrophysiological tests, like the ERG, what it does is to measure the change in the resting potential of the eye. In neuroophthalmology, the importance of ERG is in that if you don't know the ERG, you do not know if the ERG is normal, you can rule out that it is a retinal pathology. Otherwise, in neuroophthalmology, the ERG as such does, especially the full field ERG, does not have any relevance. The pattern ERG, on the other hand, is important because the macular fibers the function of the macular fibers is given by the pattern ERG, and this can directly convert to optic nerve function as well. So if you suspect a macular pathology, ideally you should have both the pattern ERG and the pattern VEP for you to make a distinction between whether it is a macular pathology or a optic nerve pathology. I will not go into details of the ERG. Again, the multifocal ERG also gives you some more information about the macula. So if you are suspecting something that is whether it is macular or whether it is optic nerve, again, multifocal ERG will also be important for you. This we have covered. So next we'll go to the important topic, which is the visual evoked potential. And this is an important test in the investigation of suspected optic nerve disease. And the diagnostic VEP, what we call the pattern VEP, is a reversing black and white checkerboard or grating. And this is of importance, especially when you want to look at misrouting of optic nerve and chiasmal fibers. The flash VEP is just a overall indication of whether the visual pathway from the eye to the brain is working or not. It cannot give us any more other information. And this measures the electrical signal generated at the visual cortex in response to visual stimulation, and it requires a relatively normal retinal or macular function to be a reliable test of visual pathway function, what we said earlier. The pattern reversal VEP will go directly into the components. I don't think we should go into the method. So this is what the pattern VEP looks like. There is a positive deflection at about 100 milliseconds. The negative deflections that occur at 75, what is called N75 and N135. Now reduced there are two things that we look at here, the latency and the amplitude. The reduced amplitude and increased peak time of P100 means the latency. So these two typically occur in optic neuropathies or optic neuritis, can also occur in maculopathies. That is why it is important for you to do the pattern ERG or the multifocal ERG earlier. And it should be read in conjunction with the retinal function test. So where do we use the pattern VEP? You can use it in optic neuritis, in multiple sclerosis, compressive lesions of the optic nerve, cortical blindness, unexplained vision loss, and also as a test of visual acuity. Now, in the optic nerve dysfunction, which is due to demyelination, the most important sign is the delay in the latency. Reduction in amplitude can occur in visual disturbance proximal to the optic nerve or neuronal tissue and is usually atrophic or ischemic, not demyelinating. Absence of VEP on monoocular stimulation again is a lesion of ipsilateral optic nerve. And we also talked about the prolonged P100 latency is an indication of demyelination. In optic neuritis, there will be disc pallor, thinning of the retinal nerve fiber once it is Most diagnostic during the time of optic neuritis, as well as in conditions of demyelination, this P100 latency almost never comes back to normal. So it is also an indication, especially in MS patients who have had subclinical optic neuritis. If you want to look at whether there was some optic nerve dysfunction during an episode, again you can look at the P100 latency. This is a delayed VEP 7 months following left optic neuritis in a 39-year-old male. And the delay is present both in pattern and flash VEPs. And however, right eye findings do not show any significant abnormality. The early optic neuritis nerve asymmetry. Early unilateral optic neuritis you can pick up if you have bilateral VEPs, and you can find that the left eye peak latencies are significantly slow. Pattern reversal VEP from bilateral optic neuritis, you can see they are symmetrically delayed. Later stage optic neuritis after initial onset showing progressively slower P100s. In trauma, what do we do? Use it in trauma for traumatic optic neuropathy. So immediately after severe trauma, if you have traumatic optic neuropathy, you can get no recordable VEPs. And however, sometimes it is because of the inflammation. So when you're doing it immediately after trauma, it should be interpreted with a pinch of salt, and you should repeat the VEP. Do not write off the optic nerve without repeating the VEP maybe a month later, so that because once the inflammation subsides, some amount of optic nerve function may come back. So even if the VEP is unrecordable, we can go ahead and repeat it later. Flash VEPs 1 month after occipital trauma showing some recovery of earlier one had no one at all, the one previously, and then now you can see that there is some amount of waves coming, and then 3 months after there is more further recovery. In patients with neurofibromatosis type 1 who have optic nerve gliomas, again VEP is a sensitive test for follow-up, because these patients, many of the time we do not intervene, and we look at visual acuity and visual fields ideally, but in these, sometimes with children you cannot look at visual fields and visual acuity. Because of that, the VEP follow-up is very important, because sometimes we finally intervene when the VEP is significantly showing changes over time. In other compressive conditions like hydrocephalus affecting the visual pathways, again VEP is important. Ischemic optic neuropathy, it is mainly to differentiate ischemic optic neuropathy from demyelinating optic neuropathy. So because of that, you will find that it is a decrease in the reduction in the amplitude without any change in the latency in non-arthritic AION, and more severe in arthritic AION. The pattern VEP in retrobulbar left eye neuritis, you can see that it is affected, and in the left eye of a patient with posterior ischemic neuropathy also you can see that it is affected, but the P100 will be normal. When you have an unknown cause of a pale disc, again you can quantify and follow the progression of optic nerve hypoplasia or optic atrophy or a pale disc due to any cause with the VEP. Another important thing that we use the VEP now for is the ethambutol toxicity. In screening, we cannot keep repeating the VEP every month, but if you have a suspicion that the patient has ethambutol toxicity, it is ideal to do the VEP and record the response, so that it gives you again a functional evidence that the optic nerve function is affected. And you will get delayed peak times in ethambutol toxicity. Next, another new one that has come is the multifocal VEP. Here, over 100 channels of the optic pathway are assessed in by the VEP activity is assessed. It's a new kid on the block, and it requires like a lot of studies to come out to know where we exactly can use the multifocal VEP. So in conclusion, the electrophysiological tests are an important thing in your armamentarium. You may not be able to use it all the time, but in some conditions, it definitely gives us an edge over our clinical examination and our other functional tests that we do. Thank you.
Thank you, ma'am, for that very nice talk covering the most important or the needed aspects of electrophysiology. Ma'am will be leaving now. Any questions to ma'am? from the
people.
from the two people.
Everyone else can ask at home.
Okay.
Okay. Total toxicity, you expect a decrease in the amplitude, not much in the വേണമെന്നില്ല. Amplitude reduction, the baseline VEP is not being addressed, but if you suspect that it's going on, you need a recording of the VEP showing a decreased amplitude. It will show before visual acuity drop, but again we can't use it as a screening tool because it is not widely available. So as of now, visual acuity, visual field, color vision and pupils are the way to screen, but visual field, especially the 24-2 or the 10-2, so are the way to screen. But if you suspect, before you send the patient for saying that it is a temporal toxicity, it is ideal that we do an MRI and a VEP also. MRI to rule out any other cause for optic nerve dysfunction, and VEP to record that there is definite optic nerve. Thank you.
Thank you, ma'am.